I think I was instructed to just maintain the podium here to start on the next talk, which deals with one of the messiest, chaotic, difficult to understand segments of glomerular disease that we encounter. In fact, up until 2-3 years ago, the field of FSGS was in great disarray. There has been some improvement in our understanding and our thinking processes relating to FSGS as a lesion, and I'm going to try to cover those because they all fundamentally develop as a result of a misunderstanding. For decades, it has been considered that FSGS was a disease. It is not a disease. It is a lesion, a pattern of injury caused by many diseases. And the fact that we have only recently understood in a more detailed fashion what those diseases are, that we are beginning to have a better understanding of how to manage this very complicated but common disorder. So what I'd like to do in the next 35 or 40 minutes is to bring you up to date on the lesion of FSGS. I have a number of potential conflicts and disclosures. Some of them are related to FSGS, but I can assure you they will have no impact on the type of information I share with you today. So I'd like to start with a case. This is a real case, not a hypothetical case. This is a patient I saw about a year and a half ago in consultation. A 19-year-old man is referred to you for advice regarding the diagnosis and treatment of his kidney disease. About a year ago, he was found to have overt nephrotic syndrome with a low serum albumin and a quite high urinary protein excretion rate. His serum creatinine was 1.3, giving an eGFR of 79, which would be low for a 19-year-old man. His blood pressure was elevated, and the usual serologic tests were negative. A renal biopsy had been performed, which revealed focal and segmental glomerulosclerosis of the not otherwise specified variety. We'll come to that later, involving 3 of 15 glomeruli. And electron microscopy showed very diffuse effacement of the foot processes. About 90% of the foot processes were effaced. And the immunofluorescence showed 2+ mesangial deposition of IgM and C3, largely in the areas of focal sclerosis. On deep questioning, his mother recalls some kind of kidney disease in a cousin. That's all the information she can supply. Here is the biopsy showing the segmental glomerulosclerosis in one glomerulus. Because of the finding on renal biopsy, he started on high-dose glucocorticoid therapy in tapering doses, which he took religiously for 6 months, and the urinary protein excretion rate declined modestly to 6.8 grams per day, and his serum albumin increased somewhat to 2.4 grams per deciliter, but the serum creatinine remained unchanged. He is now tapered completely off his steroids and is taking an angiotensin receptor blocker, and his urinary protein excretion rate is now 4.1 grams per day. His serum albumin is 3.0, and his serum creatinine is now 1.75 with an eGFR of 55 mLs per minute. You're asked to answer one of these 5 options, and I don't need you to raise your hands or answer. I'm going to come back to this at the end of the talk, but if you'll think about these questions as I go through the rest of the material. Would you repeat his renal biopsy? Remember, his renal function is deteriorating, his renal protein excretion and serum albumin are improving, and he was completely steroid refractory. Perform a targeted genetic screening with whole exon sequencing. Start a calcineurin inhibitor. Start mycophenolate mofetil, or give a course of rituximab. I won't ask your opinion about this. Maybe later on we can ask the audience to respond. Well, I want to start with some key points that I'll try to address during this talk. Perhaps the most important is that focal and segmental glomerulosclerosis, FSGS, is a histological pattern of injury defined by its light microscopic appearance. It is not a specific disease entity. It can be the result of a wide variety of pathogenetic processes. The lesions found in the kidney are very heterogeneous by light microscopy, and electron microscopy is absolutely essential. It is required for full evaluation of this lesion. And the lesion is a misnomer because it's only focal by light microscopy. It is diffuse by electron microscopy, involving every glomerulus. There are three fundamental forms of the lesion of FSGS. The primary or idiopathic form, which is always a diagnosis of exclusion. Even though it is regarded to be a single disease, it probably is heterogeneous. It is likely related in some way to minimal change disease in that it is due to a circulating factor which is toxic to podocytes, and many people call this disease primary permeability factor related FSGS. Genetic and heredofamilial forms of FSGS are increasingly recognized. And as of a few weeks ago, there were over 50 mono or digenic mutations identified, either of autosomal dominant, autosomal recessive, X-linked, or mitochondrial inheritance patterns, and I would expect that 50 is not going to be the final number because additional genetic mutations are being examined as we speak. The remaining forms of the FSGS lesion are collectively called secondary FSGS. They can be due to an identifiable disease in some cases, and in many cases one cannot really identify it. All that one can tell is that it's not likely to be primary and not likely to be genetic. About 35 of specific entities have been identified so far. Now, the genetic forms of FSGS, comprising 50 separate individual mutations, can be either monogenic or digenic. They commonly underlie FSGS in children, probably a little less so in adults, and we'll be discussing this in more detail later. The inheritance patterns are quite variable, and there are some cases in which there is a sporadic or de novo mutation. About 90% of these 50 possible mutations are found at 6 loci: NPHS1, NPHS2, TRPC6, IFN2, alpha-actinin 4, and PLC1. 90% can be determined by these 6 exons. Now, polymorphic alleles at the ApoL1 locus are found in association with FSGS, particularly of the collapsing variety, in African Americans only. There may be lesions of FSGS found in other genetic diseases, like Fabry's disease, which is a lysosomal disorder and involving podocyte deposition of ceramide, which can lead to focal sclerosis. This is a genetic form of FSGS, not due to mutation of a podocyte gene or a basement membrane gene. We'll be discussing when to do pre-therapy screening and when to consider screening for these genetic forms of FSGS in steroid-unsensitive patients. Subtle genetic mutations, which are subclinical in healthy individuals, may be exposed to clinical expression when another process is superimposed, such as obesity. And subjects who are massively obese and who possess these susceptibility genes may develop a lesion of FSGS very similar to the lesions found in non-obese patients with overt genetic mutations. Now, the number of mutations or genes that can be involved are growing each day. This diagram illustrates but a few of them involving the podocyte nucleus, the slit membrane, the actin-binding proteins, the mitochondria, and a number of genes that involve the basement membrane, which are not shown in this slide, such as the collagen 4 alpha 3 and 4 and 5 proteins, which can be genetically altered and lead to the lesion of FSGS. Now, in children, the genetic forms of FSGS are quite common, particularly in infants, where infants displaying the lesion of FSGS have a genetic origin in about 70% of patients under the age of 3, and this decreases in age up to adolescence, and then it remains fairly stable during adult life. Now, it's shown as 11% in age 13 to 18 in this particular study, but the number of exons studied in this particular study group were rather limited, and the more exons you study, the more mutations you find and the higher the prevalence of genetic forms of FSGS. In a recent paper published in the New England Journal by Groupman, shown here in orange, glomerular disease can be associated with a very high frequency of mutations detected by exon sequencing, particularly at the collagen 3, 4, and 5 locus. That is the same locus associated with Alport syndrome and thin basement membrane nephropathy. And it turns out that these basement membrane-related mutations, not podocyte mutations, are a fairly common cause of FSGS lesions in patients with nephrotic syndrome. Now, the secondary forms of FSGS can be broken down into a number of causes, such as infections, neoplasia, drugs, oligonephronia or nephron deficiency states, maladaptive states, and lesions of FSGS superimposed on other primary renal diseases such as IgA nephropathy, membranous nephropathy, and others. Basically, these non-primary forms of FSGS break down into 8 general categories. We've discussed the genetic forms, and then infection, neoplasia, drugs, nephropenia, maladaptive, and superimposed constitute the remainder. So if primary FSGS is a diagnosis of exclusion, all of these need to be considered. Many of them will, if present, will be obvious, such as vesicoureteral reflux, a solid or a liquid cancer, viral disease, and drug-associated FSGS. It is remarkable that the non-primary forms of FSGS, the genetic and the secondary forms, have a tendency for very slow progression, the development of non-nephrotic proteinuria, and persistently normal albumin levels in the serum, and also by an extraordinary resistance to steroid therapy and a low risk of recurrence in the renal allograft. All of these are important elements of the non-primary genetic or secondary forms of FSGS. Now, primary, hereditary, and secondary FSGS all come in a variety of histopathologic patterns or flavors. Now, these subvariants of the FSGS lesions probably have very limited utility in determining the underlying cause, pathogenesis, or management of the patients. And in fact, some very reputable pathologists, including one in this city, who you may know because he's presented here a number of times, Dr. Renke, disregards this classification system entirely and says it has no pathologic or clinical utility. However, other pathologists disagree with this opinion. I'll show you the Fogo-Degati, also known as the Columbia classification of the subvariants of the FSGS lesion, but frankly, I don't pay a lot of attention to them, although some pathologists, as I said, do. They are the classic, the perihilar, the cellular, the tip, and I personally believe, and I know many pathologists share this opinion, that collapsing FSGS should be considered as an entirely separate category. It's a disease in and of itself, and probably need not be considered a variant. Here are the various histological appearances of the three major variants, the not otherwise specified on your left, the tip variant in the middle, and the collapsing variant on your right-hand side. Each of these can be associated with some variation in clinical features. For example, severe nephrotic syndrome and impaired renal function is frequently found in the collapsing variety, whereas severe nephrotic syndrome and impaired renal function is less frequently seen in the FSGS, NOS, and TIP variants. So the lesion of FSGS, as distinct from the diseases causing FSGS, need to be carefully analyzed, and primary FSGS is always a diagnosis of exclusion. There is no such thing as renal biopsy proven primary FSGS, at least by light microscopy. And when you see that written in a paper or an introduction to a manuscript, you should be very suspicious. It requires something beyond light microscopy to help to define primary FSGS. Now, we don't know what the pathogenesis of primary FSGS is. It seems to be due to a permeability factor or factors. We don't even know which factors are most important, but we do know without any doubt that primary FSGS has a great tendency to recur in the renal allograft, suggesting that it is a systemic disorder and that when the permeability factor persists, a renal allograft may be damaged as a result of exposure to this circulating factor. The reverse is also true. If you transplant a kidney having a lesion of FSGS into a subject who does not have FSGS, the lesion will disappear. So it goes both ways. It can recur in the presence of a permeability factor, and it can be reversed in the absence of a permeability factor. Unfortunately, there is no single clinical or laboratory biomarker that can unequivocally and positively identify primary FSGS. There is no test other than a careful examination of the renal biopsy that can help to define primary FSGS. So what is the clinical approach to the diagnosis? Well, primary focal and segmental glomerulosclerosis is most commonly associated with a full-blown nephrotic syndrome, which can in some patients have a very abrupt onset, although more typically it's an indolent, slowly developing process in which the urinary protein excretion exceeds 3.5 grams per deciliter, and the serum albumin is less than 3.5 grams per deciliter, 3.5 grams per day and 3.5 grams per deciliter, full-blown nephrotic syndrome. Not just nephrotic range proteinuria with normal serum albumin, and not with subnephrotic proteinuria. These are nephrotic subjects. The urinary albumin to total protein ratio in a spot urine is always over 50%, and most often over 80%. But urine microscopy, the sediment examination, is very variable and not very helpful in making a diagnosis. Immunofluorescent findings are variable, but as I've mentioned, IgM and C3 deposits are seen commonly, and they may, as I'll show you in a minute, have prognostic significance. The most important finding, and if omitted, can lead to a misdiagnosis, is that electron microscopy shows extensive foot process effacement, almost identical to that seen in minimal change disease. So FSGS is a diffuse disease when one examines this by electron microscopy during active nephrotic syndrome and in a glomerulus that is not undergoing advanced sclerosis. The level of serum albumin can be a very helpful tool, as shown by this study in Praga, published many years ago, looking at patients with hypoalbuminemia and an FSGS lesion and nephrotic range proteinuria. 100% of them had presumed primary FSGS after an extremely thorough evaluation for secondary causes, not including genetic analysis, which was not available at that time. Whereas normal albumin levels with an FSGS lesion, even with proteinuria over 3.5 grams per day, primary FSGS was found in only 10% of the patients. So a serum albumin level is a helpful tool in differentiating primary from secondary, probably also including genetic, at least in some cases. So the thing I want to emphasize is the importance of electron microscopy for enhanced accuracy in differentiating primary from secondary FSGS, but it's not a perfect tool because diffuse foot process effacement is commonly seen in drug or infection-associated FSGS, such as HIV or bisphosphonates, and it is nearly always seen in the collapsing lesion, and electron microscopy does not reliably distinguish a genetic from a primary FSGS lesion. So although electron microscopy is extremely helpful, it is not perfect in allowing you to arrive at a diagnosis of primary FSGS. That's why I say there is no such thing as biopsy-proven primary FSGS. It is a misnomer. Now, extensive and diffuse foot process effacement over at least 80% of the glomerular capillary surface with a broadened foot process width greater than 1,500 nanometers in an intact, non-sclerotic glomerulus indicates a primary or a genetic form of FSGS unless the patient has a collapsing lesion, has a viral disease, or is taking drugs. And if you see segmental foot process effacement in a non-sclerotic glomerulus, this usually indicates a secondary form. Here are two virtually identical appearing glomeruli, top and bottom, with a focal and segmental lesion, but in one of these two cases, there is diffuse foot process effacement, as shown in D. There's virtually no intact podocytes left, whereas in the top form, you can see many intact podocytes. Now, I emphasize again, because this is an important thing to recognize, there isn't any serum or urinary biomarker that accurately, reproducibly, and positively distinguishes primary from secondary or genetic FSGS, but serum albumin concentration is a useful biomarker to separate primary from secondary FSGS. SUPAR, serum urokinase-related plasminogen activator receptor levels, were thought to be the next biomarker for FSGS, published first by We in Nature Medicine, 2011. 75% or so of patients with FSGS had elevated SUPAR levels. These were not seen in patients with minimal change disease, and they were intermediate in membranous nephropathy. However, this turned out to be simply the fact that the serum creatinine was different in these three groups, and when the serum creatinine is elevated, so is the SUPAR level. So it's really a biomarker of impaired renal function, not a biomarker of the nature of kidney disease. So Sanjeev Sethi and Fernando Fervenza and I tried to put this together in a suggested approach to the diagnosis of FSGS in a patient with a lesion of FSGS, excluding the collapsing form. One uses the presence or absence of nephrotic syndrome and the degree of foot process effacement seen in electron microscopy. Segmental foot process effacement and the absence of nephrotic syndrome is a clue to secondary FSGS. Nephrotic syndrome and diffuse foot process effacement is used as a signal of primary FSGS. Now, we went a little step further in a paper published in 2018 in which an algorithm for the diagnostic evaluation of an FSGS lesion was described, which repeated the earlier suggestion of using nephrotic syndrome and foot process effacement, leading to treatment of the primary lesion with steroids, and in the steroid unresponsive form of the disease, that genetic testing should be seriously considered to separate the steroid unresponsive lesion of primary FSGS from the genetic forms of FSGS. After all, not every patient with primary non-genetic FSGS will respond to steroids. If they did, I wouldn't be here talking about this disease. Only about 60% of them. So in the 40% of patients with primary FSGS, with nephrotic syndrome and low serum albumin who fail to respond to steroids, one has to think about the possibility of a genetic form of FSGS, and that is the point where genetic screening, particularly with whole exon sequencing, may be particularly valuable. I've already told you how valuable it is in children. And in adults, emerging evidence is suggesting that if you use a very broad panel of whole exon sequencing, theoretically up to the 50 genes that are associated with FSGS, you can detect a pathogenic mutation in somewhere between 15 and 30% of adults with steroid-resistant forms of FSGS. This is important because further treatment of these patients with other drugs will only lead to toxicity, and these patients have a very low prevalence of recurrence of FSGS in the renal allograft. Now, the prognosis of primary FSGS is well known to all of you. Spontaneous remissions are uncommon. The magnitude of proteinuria and its persistence are the main drivers of progression to end-stage renal disease. And of course, this means that the response to treatment, which means disappearance of proteinuria or its reduction, are also the main drivers of prognosis. Now, there are other factors that are useful in determining prognosis or the renal outcome. The age at onset, the long-term course is better in children than in adults. Females do better than males. African Americans may do poorly because they have ApoL1 risk alleles. Hypertensive patients, those with low baseline eGFR, obese patients with hyperlipidemia and hyperuricemia may do poor. In particular, we're now recognizing that children who have low birth weights and therefore low nephron endowments, if they get FSGS, have a very poor prognosis. I'll be discussing later on some of the pathological features that indicate a poor prognosis, including both light microscopy and immunofluorescence microscopy. But the most important feature by far is what happens to the proteinuria. If the patient develops a remission and either partial or complete, renal survival is extended. If the patient remains nephrotic and is steroid unresponsive, the prognosis is poor, and the extent of risk for developing end-stage renal disease increases as the magnitude of proteinuria increases. In fact, the 50% renal survival rate in a patient who has primary FSGS and is excreting over 14 grams of proteinuria per day is only about 3 years. So it can have a very malignant progression with rapid development of end-stage renal disease if proteinuria is severe. In patients with FSGS lesion, the rate of decline of renal function is linearly related to the magnitude of proteinuria, here shown in the columns in red. As the proteinuria, the time average proteinuria increases, the rate of GFR decline increases. And if you have a partial or complete remission, the rate of decline in renal function decreases. Now, in patients who have urinary protein excretion above around 2.5 grams per day, the decline of GFR in milliliters per minute per 1.73 meters per year is around 3, or maybe a little higher. So a 30% decline in GFR from a baseline of 60 would be expected to occur in about 6 years in a subject with FSGS and a time average proteinuria of around 2.5 grams of proteinuria per day. A clinical trial that is only 3 years in duration is never going to have enough end-stage renal failure events to show a beneficial effect. So the trials that are conducted with treatment of the FSGS lesion in patients that have less than 2.5 or 3 grams of proteinuria per day cannot determine whether the drug is or is not effective for preventing end-stage renal disease. It requires much higher levels of proteinuria. Now, I'd like to finish with a few comments about treatment of FSGS in 2019 using the 2012 KDIGO guidelines. In about 4 months, these guidelines will be obsolete because the new KDIGO guidelines will be issued in November of 2019, and I can assure you that the guidelines for FSGS will change dramatically from that which I am sharing with you based on the 2012. Secondary and genetic forms of FSGS, if they are identified, should be treated by correction of the underlying disease if possible. That can't be done with genetic diseases. Using nonspecific anti-proteinuric agents, mainly RAS inhibition, not with steroids. These are steroid-resistant lesions. Now, intensive calcineurin regimens can be effective in some forms of genetic FSGS, but this has never been tested in a randomized controlled trial. So if you use calcineurin inhibitors to treat a steroid-resistant patient with a known genetic mutation, it's an experimental form of treatment because we don't know what it will do. And of course, it's a potential toxic regimen. If you have a patient with presumed primary FSGS, based on nephrotic syndrome, diffuse foot process effacement, and exclusion of the commonest forms and no familial tendency, these patients should be treated conservatively if their urine protein excretion is less than around 3.5 grams per day. Now, some would say, well, why not 2.5 grams per day? Because that is associated with future progression. The problem is there's no trials to test that hypothesis. If you have primary FSGS with nephrotic syndrome, a low serum albumin, prolonged high-dose oral glucocorticoid therapy is the treatment of choice at the moment, and you have to continue this for a fairly long period of time in order to achieve a remission. This is a serious problem because many patients cannot tolerate that kind of doses of steroids without serious side effects. And this is one of the major challenges going forward, is to find a strategy that is effective that allows a reduction in the total exposure to steroids. Now, the aim of management of FSGS, of the primary form, is to reverse, halt, or delay the progression to end-stage renal failure and to develop a complete or partial remission of proteinuria, largely to avoid many of the complications of nephrotic syndrome, including cardiovascular disease and thrombosis. But of course, we want to do this without a lot of undesirable side effects, including renal side effects and non-renal side effects. Now, the non-specific approach to the treatment of FSGS, which would apply to all patients, not just primary FSGS, but genetic forms as well as secondary forms, are control the blood pressure, use anti-proteinuric agents like RAS inhibition, treat the patient's volume expansion with sodium chloride restriction and diuretics. If the patient has a very low serum albumin, consider anticoagulation for prevention of thromboembolism, although the risk is relatively small in FSGS. Treat the hyperlipidemia. If hyperuricemia is present, it perhaps should be treated, although there are no controlled trials showing a benefit. And modulation of dietary protein might be considered, but there's no evidence of efficacy, and low-protein diets may be unsafe in this situation. Now, these forms of nonspecific therapy of FSGS lesion with RAS inhibition tends to be much less effective in patients with primary FSGS. In fact, there is not a single randomized controlled trial of RAS inhibition in primary FSGS that shows a benefit. Not a single one. However, in secondary FSGS and perhaps in genetic FSGS similarly, RAS inhibition appears to be more effective. Steroids in high dose over a long period of time are only indicated in primary FSGS, as all of the secondary and genetic forms tend to be very unresponsive. I could show you many trials, most of which are uncontrolled and observational, indicating the likelihood of a response to steroids. In adults, it's about 60% or so, 33% complete and partial, about 30%. And the 10-year survival rate in patients who respond with a complete or partial remission is 92%. Renal survival, whereas it's only 30 or 33% for non-responder, and there's really no difference in the 10-year renal survival based on the response to treatment between patients with TIP, not otherwise specified, or collapsing lesions. As I mentioned earlier, immunofluorescence studies have shown some influence on prognosis because if the lesion shows a lot of IgM and C3, the patients who are refractory to treatment increase, as shown in this Chinese study, and complete remissions fall from around 60 or 65% to 35% in patients who have these kinds of deposits of IgM and C3 in the FSGS lesion. So glucocorticoids are the main approach to treatment, with calcineurin agents being reserved for steroid-unresponsive patients with primary disease, and then a whole host of other approaches, most of which have never been tested in randomized controlled trials, and in which we only have anecdotes of efficacy or failure. These include mycophenolate salts, cyclophosphamide, ACTH, rituximab, abatacept, plasma exchange, and a number of other experimental approaches. ACTH has about a 30% response rate in only one observational trial, and a randomized controlled trial is in progress. Cyclophosphamide is completely ineffective, never indicated in steroid-unresponsive primary FSGS. So the standard of care in 2019, in my opinion, is steroids first in most cases. The total dose and duration has to be very extended, and it may not be achievable in many patients. Cyclosporin or tacrolimus, and I tend to prefer cyclosporin, with or without low-dose steroids, can be used for steroid-resistant patients or in the case of initial response with relapses. There is some information now emerging that calcineurin agents can be considered for primary initial therapy, but it's never been proven that such CNI first regimens have superior long-range results compared to steroid monotherapy. This is the only observational study I could find. This is about a 3-year follow-up showing no difference in the ESRD rate when you use CNIs first as opposed to steroids first. But if you have a patient in whom you want to avoid any exposure to steroids, like a diabetic or a very obese patient, CNIs may be a perfectly acceptable initial treatment. As I mentioned, the KDIGO guidelines for treatment of FSGS will be released in November of 2019, so stay tuned. So the take-home messages for this talk today: FSGS is not a disease, it's a pattern of injury. It is a podocytopathy of very diverse pathogenesis. Electron microscopy is essential, and there are no reliable serum or urine biomarkers. Remissions are more important than histology for long-term outcomes, so repeat renal biopsies have little or any role in the management of patients with FSGS once you have an established lesion. Genetic testing going forward, particularly whole exon sequencing, is going to be critical for the management of steroid-unresponsive adults. And screening prior to treatment may be justified in children. Now, I asked you a little bit about this case, the 19-year-old man, 22-year-old man, given steroids, no response, had a weak family history, but had lesions of diffuse foot process effacement and low serum albumin. He's now off steroids and has had a partial response to RAS inhibition. What are you going to do? A repeat renal biopsy will be of no help. Targeted whole exon sequence might identify a mutation which will help guide your future management, particularly transplantation. Calcineurin inhibitors will be of no value if the patient has a genetic lesion, and in the face of reduced renal function, it may be toxic. And mycophenolate mofetil and rituximab have never been shown to be clearly efficacious, and therefore the choice is B, perform targeted whole exon sequencing.